Hi, and welcome to the Embouchure Project podcast, where we bring together the finest minds in the world to help understand the complex system that is the embouchure. The Embouchure Project represents a network of neurologists, scientists, physical therapists, psychologists, and pedagogues. The goal is to help define what a healthy embouchure is, what we can do to optimize the embouchure, and to deal with problems as they arise. A lot of our time will be devoted to embouchure dysfunction, from minor annoyances to debilitating forms of dystonia. We hope that all players, teachers and medical professionals will find this to be a rich resource. My name is Frankie Lacerdo. I'm a horn player with the West Australian Symphony Orchestra, founder of Brass Rehab, and on faculty as a teacher at the University of Western Australia. Thank you for joining us. We hope you find this to be informative and helpful. The Embouchure Project would like to thank the Australian Society of Performing Arts Healthcare and the Glenn Gould School for their support. Today we welcome Dr. Xenos Mason. Xenos is a founding member of the Embouchure Project and a force behind much of the medical research resulting from the project. He's Assistant Professor of Clinical Neurological Surgery and Neurology at the Keck School of Medicine at the University of Southern California. Having completed medical training at the Harvard Medical School, Massachusetts General Hospital and UCLA. He is a movement disorder specialist with a special interest in deep brain stimulation, novel neuroimaging and forms of occupational dystonia, including musician's dystonia and embouchure syndrome. He is an avid amateur horn player and continues to make music a central part of his life. Let's meet him now. Well, welcome back to the Embouchure Project podcast. My name's Frankie Lacerdo, and we're really lucky to have neurologist Dr. Xenos Mason. How are you going?
I'm going well. It's nice to be here.
Thanks so much for taking the time to be with us today. It's really exciting. So I just want to start by asking you to just maybe tell us a little bit about yourself. I know that you used to be a horn player and now you're a doctor. How does that tell us how you became where you are?
Yeah. Well, I'm still a bit of a horn player, but in an amateur sense. So I've tried to keep that up as much as possible. But I was a horn player, more avidly as I was growing up, as many sort of children and teenagers are, and I just sort of stuck with it through university. And then, but I was always interested in medicine as a career path. So I headed in that direction, and I kept playing during medical school. I was able to play in a couple of the campus orchestras with other graduate students, and play in some community orchestras during university, and a little bit onwards now. I play in a community orchestra actually as I practice in Los Angeles. So I've been a little bit all over. I mean, I trained in Boston and then did my fellowship in Los Angeles. So from Toronto, I went to the East Coast and then to the West Coast, and I've been here in Los Angeles since 2019.
It's the American way, isn't it? You don't study in your hometown.
Yeah, well, that's right, and it's very much not the Canadian way too. So it's a bit of a mind shift in that sense. But
yeah,
but it's fun to explore, and it's especially fun to see the cultural differences in medicine and music. And get a little bit of both worlds.
Yeah. So speaking of medicine, you're a neurologist. So what are you doing at the moment? Like, from what I can tell, you're kind of at the forefront. You're in the trenches, like front of the line of kind of the latest things that are happening, especially in terms of neurology for musicians. And tell us a bit about what you're doing at the moment.
Well, so I've trained in what's known as movement disorders. So it's a subspecialty of neurology. So within neurology, most people these days do some subspecialty training. And so even though it seems from the outside like neurology is specialized enough, it's the field has gone in such a way that now some people do epilepsy and specialize there, but other people do headache. So movement disorders is this interesting specialty that kind of, it arose in the 1960s, 1950s as kind of an independent specialty when we'd known about Parkinson's disease for a long time, but it began to be observed that when we were treating Parkinson's disease with some medications, we could make someone with Parkinson's look a lot like they had a Huntington's disease, completely different disorder. And that was, as a result of the Parkinson's disease, but also the medications. And so there's this interesting link there between diseases where there's too little movement and diseases where there's excess movement. And, long story short, over decades, it began to be understood that a lot of these disorders are unified sort of anatomically by a structure in the deeper part of the brain. It's called the basal ganglia. But it's really across movement, across thought, across sensation, really all the functions that the brain does, the basal ganglia helps to regulate. And so it's this interesting structure it's a regulator of a very chaotic system. The outside of the brain, the cortex, is very chaotic and it's prone to seizures, for example. So the basal ganglia helps to regulate and decide what to do and what not to do. So movement disorders is this specialty that arose from an anatomical understanding and a biophysical, a neurochemical understanding of what these structures do and how all of these disorders are kind of unified by their origination in this anatomical structure. So I see patients with Parkinson's disease, I see patients with tremor disorders and other disorders of excess movement. So that's the subspecialty that I'm in. And from there, musicians can suffer from some of these disorders, and uniquely they can suffer from disorders of excess movement that can affect their playing, like embouchure dystonia. Yeah. But there's also plenty of musicians with Parkinson's disease or tremor. And so there's a question of, well, do we need specific treatments for musicians with those disorders? And how do we properly care for them and appreciate that they have specific needs?
Yeah, right. Yeah. And from what I understand, one of your specialties is you're passionate about deep brain stimulation. Can you just kind of flesh out what that is?
Yeah, that's it. So it is. It's a big part of my practice. It's probably about 50%, 75% of what I do. So it is somewhat what it sounds like. So we're stimulating the deep parts of the brain, that's the basal ganglia, with electricity. And we do that to treat symptoms of movement disorders. And also we can treat epilepsy. And now it is emerging that we can treat some psychiatric disorders like obsessive compulsive disorder and depression with this technique as well. So the long story short, again, is that it's basically a pacemaker for the brain. So there's a battery in the chest. It's connected to some wires in the neck. And then a neurosurgeon implants an electrode on 2 electrodes, one on either side, that deliver electricity. And by changing the way that the electricity is delivered, we can change the way that the treatment focuses on specific symptoms. We can deliver it to very, very specific sort of subregions in order to target specific symptoms. But generally, it's a way to treat all of these patients who have symptoms that are affecting their quality of life that are not responding sufficiently to medications. And so it's an amazing tool in the toolbox, and it's one that's particularly satisfying in neurology because, unlike a lot of things, you see the effect instantaneously.
Yeah. Wow. And so in the musical world, what kind of things are you finding out at the moment, or how are you using your knowledge as a musician, as a horn player, and how are you kind of relaying it to people, say, with focal dystonia or tremors in their face?
I think, yeah, exactly. Tremors in the face, in the hand, in a pianist or a violinist. It's really any part of the body that's very, very highly trained to participate in the music making process can be affected by one of these disorders, and even mild symptoms, it becomes disabling. So I think the key, you need to have an anatomical understanding of how the brain works and a little bit of the physiology, at least the physiology we understand, the neurophysiology. It's poorly understood. But also just appreciating that musicians have specific needs and that very, very mild symptoms in one domain, that might not affect somebody else's quality of life, really need to be addressed carefully. Like, for example, I saw a wonderful a wonderful man. He was a guitar player and is a guitar player, excuse me, and a songwriter. And so he had and has Parkinson's disease, and his symptoms of slowness in mostly his right hand were affecting his ability to play the guitar. And that's all well and good. He doesn't make a lot of money playing guitar, but it does affect his creative process, because it's in the process of, just jamming that he produces melody, and that's his creative outlet, and also his job and the way he makes money. So, a little bit of mild slowness in the right hand for most people wouldn't be so disruptive, but for him, not only is it his vocation, but it's his passion that he can't participate in. I think that it's just a mindset. Yeah. Excuse me.
Yeah. From what I've read, so the statistics for, let's say, focal dystonia in the general population is 1 in a million, but for like musicians, it's more like 1 in 1,000. Is that correct? Or so you were talking about, definitely it's more prevalent in musicians because these fine motor skills and everything. Can you talk a bit about why this is the case? I don't know if I've got my numbers mixed up, but so why is it that we're so much more at risk of stuff like this?
So the honest answer is that it's incompletely and poorly understood, because although there's been good studies done, there haven't been very many of them.
Okay.
And one of the numbers that you said, 1 in a million, it more represents the more rare forms of generalized dystonia that affect the whole body. But actually, if you take all comers with dystonia, say in the American population, it is about 1 in 1,000.
Yeah, right. Okay.
And so, musicians are probably suffering from dystonia at slightly higher rates for one reason I think is likely. The other is just conjectural on my part. But mild symptoms are going to express themselves very commonly, right? So it may just be a bit of a selection bias in musicians that even mild dystonic symptoms in a limb or in the face are going to be noticed and addressed. Versus just the general person might not notice them. And the other possibility is that they are a highly skilled, highly trained subset of the population, and there's a specific predisposition in people like that towards developing dystonia. So I think it is that I think there's less evidence for, but certainly it's a reasonable hypothesis, especially for embouchure dystonia and other forms of dystonia that only express themselves with particular tasks.
Fascinating. There's a couple of dying questions I've been dying to ask you. One general one, and then we're going to get into some more kind of specific, I would say, brass playing kind of questions. Can you talk a little bit about how the mental and physical are linked? So from my own experience, having an overuse injury, and going through not being able to play to coming back to my job, and also just from the people that we have helped around the world, brass players, it seems like the majority of players that have an injury, and I would say the majority of either going through something quite severe, like outside of playing, so like a marriage breakup, depression, anxiety, and I've read some studies that it is all linked as one big system. But I'd love to hear your thoughts on from your point of view and from your research, just your thoughts on this.
Oh, I love that question. It's just something that we could just talk about for days.
Hey, I've got all day. I don't teach till 4:30, so we can.
Yeah, it's a little later here, but we can go on and on. I think so. There's so many levels of that question, and so many layers to it. So maybe best illustrated by an example. Something we often see in neurology is a person who comes in with relatively mild symptoms, and overlaying on those symptoms is another process that has been come to called functional neurological disorder, but in the past it's been called hysteria or psychosomatic illness. But this idea that there is the capacity of the mind to manifest physical symptoms. That's certainly true. And there's very, very interesting work coming out of well, a number of places, but John Stone is one in particular who has written extensively about this disorder and some of the possible ways that the brain can actually produce physical symptoms out of psychological or mental starting places. So that's very, very common. And so much of our training in neurology is about differentiating those two things. One class has been called, or some so-called organic disorders, and they're thought to arise in the physical substance of the brain, a lesion or a neurodegenerative process. And this other category of things, some neurologists just really are not interested in it, and they don't like dealing with it, and they think that it's in the psychiatric realm, is functional neurological disorder. But the two are linked, and almost every patient that I see with, say, Parkinson's disease has some degree of what you might call, functional overlay. They have a neurodegenerative disease, but certainly there is a component of overlay from the psychological system that can worsen their symptoms. And so that is like only one part of the explanation. And how functional neurological disorders come about and where those come from. I mean, I could explain that a little bit, but maybe more relevant to talk about the other aspect of an explanation for this, which is emotion and drive and motivation. I mean, those things are just vitally important aspects of the way that our brain functions, because they're vitally important aspects of the way that we operate in the world. And so take, for example, that same Parkinson's disease patient. There may be a little bit of psychological overlay from stress and anxiety about the severity of their symptoms. And when they come to see me in the appointment, I can encourage them, or I can use some skills in the way that I examine them to separate that small component. But there's another component that's just about motivation. So if they're in a relaxed state, sitting in an armchair watching television, it might be very, very difficult for them to get up and move. But then there's a fire that breaks out in the kitchen, and they leap out of the chair and they run out of the house. And you think to yourself, well, what is it about the systems of the brain that are allowing that to happen, and how is that even possible? Well, it is because it's exactly the way that we're supposed to operate in the world.
And fight or flight. And
yeah. And it's it's just an illustration of how deeply tied those two things are. That's only a start of an answer to your question, but there's much more to it. I think, to be brief, there is always a psychological component to every part of our life. And neurologic disease, whether it's entirely psychological or whether it's entirely organic, is no exception.
I think it was just something that really shocked me as I kind of moved into this, from having gone through an injury to helping people with injuries. It actually almost became the first question I would ask someone. It's like, look, like, what's going on outside of horn playing, or what's going on outside of you? Because you need to take it into consideration. And a lot of the time, people with that are going through something quite traumatic weren't seeking help. It's like, well, you might want to start there, and then to help the whole system, to help your body. So that's a fantastic insight, and it's encouraging to know that that there are people looking into this area, this field, and
it's this overlap, this gray zone is becoming more and more well studied, and there's an entire
gray zone. I like that.
Yeah,
gray zone. Good.
Yeah, and so we're coming to appreciate more and more where the overlaps are. But you speak to the importance of addressing those things, and so I just want to make the point that there's not always an underlying cause. It's not always a traumatic event that precedes something like this. But there's always a role for psychological treatment, whether from a performance psychologist or from somebody who's helping you to address an underlying issue if it happens to be there.
Yeah, right. In terms of more, so we might zoom in on some playing questions. So as part of any rehabilitation from an injury, we're learning new physical techniques, or even as healthy players, we're always wanting to get better, and we want to learn new techniques or improve the technique that we already have. But I just want to ask you about. So as musicians, we're in this mindset of, practice equals results. So the more we practice, the better we get. But if you were to talk to an athlete, it's like, oh, if you just run more and more, you'll get faster. Or there's so much more understanding in the athletic world about the brain's ability to change in terms of frequency of length of practice and quality of practice. I just wanted to ask you and also your attitudes and thought patterns, and maybe if you could push back on, and also being a musician, if you could push back on the idea of practice equals results, and what's actually happening with the brain when we're practicing. So I guess that in a simpler way, how do we maximize practice?
Well, so I think you need to understand how practice actually works at a neurological level to start to answer that question. And the sports physiologists are probably only starting to figure that out, even at that level, right? But I almost have to send it back to you, because this is not, I'm an amateur, passionate amateur musician, but I have never been somebody who's good at practicing. So I don't think that I've ever practiced as many hours in a day as, in my entire life, not even once, probably, as your average day as a professional musician. So I might send it back to you to ask, how do you experience a day of practice, and what is a comfortable day of practice? What does that mean for you, or for a professional horn player?
If I had a day without working, like without rehearsals and performances, or?
Yeah. So I think it's important to understand what the body can do comfortably to answer this question on any level. But what does that look like for you?
I think as a father and as a full-time musician, and time is not on my side anymore. So I definitely have strived for efficiency and finding exercises, or like routine exercises that really hone in on my weaknesses. So I'm going for 100% efficiency when I'm practicing, and doing it in shorter amounts of time. So 20, 30-minute bouts between naps and meal times, and for my baby, not for me. And okay, he's 3 now. He's not a baby, actually. That's a bit of a help.
No, he is. He'll always be a baby.
Yeah, but I find I can squeeze in 30 minutes here and there, and they're working on things that I find challenging. And it's funny that they're things that I found challenging when I was studying, and they're still challenging for me. I know what I can leave alone, what's quite natural for me in my playing, but so I'm honing in on the things that kind of always need work. So that would be a normal day, and it's probably no more than 2 hours.
Well, I think,
normal day.
Yeah. And that fluctuates widely, I'm sure, based on your demands and based on your stress levels and based on the rest of your family life. But that to me makes a lot of intuitive sense, because you're always operating within the bounds of your physical body, and it doesn't matter if you're an elite Olympic sprinter or a pianist or a horn player. I think it really does come down to the body and embodiment of our cognition and our brain, and the ecology as well. I mean, how we're surrounding ourselves and what we're actually doing in the world. So when people ask me about what is best for the brain, and what are the best techniques that we use, and how can we do this and this in a way that is most natural for the brain, I always reflect it back and say, well, what seems most natural to you and your environment, and what seems most natural to you and your body? Because the brain didn't evolve in a vacuum. It doesn't have capacities outside of our own natural physical capacities have imbued it with, and vice versa, right? So when I think the best answer to your question is one that appreciates the physical limitations of you and I and the rest of brass players. So the best style of practice is one that doesn't stress the muscles of the embouchure so that there's an injury. It also gives time for sleep and regeneration and other tasks, and sort of split focus when you can go and do something else for a little while and come back to something and consolidate that practice. And it also makes space for the effect of anxiety and stress. And so if there's something that's causing a lot of stress, then that will naturally take your attention away from practice, and to try to hammer it into place. This doesn't work. But that's just not how that's not how we respond to stress. We just can't. So making accommodations, I think, in every situation is important for maximizing the efficiency. So I'm trying not to be, a little hand wavy with this, but the overall idea here is that the brain's capacities evolved along with our physical capacities. And so if we're trying to do something and practice and learn, I think we have to appreciate those physical capacities and learn and practice along with them. So,
listen to your body.
Yeah, exactly. Well said. You see, you've done it in 2 seconds. It took me 2 minutes.
No. I mean, I'm a cyclist, and I have a couple of friends who are professional cyclists in the pro peloton, and you hear them talking about their training, and the amount of rest time and the focus they put on rest and and sleep and nutrition and stuff. But
absolutely,
but they'll go out and train, and they'll be like, "Oh, listen to your body. Like if you don't feel good, like just don't do it." Like they say, listen to your body, not your brain. If your brain's saying, "Oh, maybe I won't go," it's like, no, listen to your body. So
yeah, I really do. We can't think our way out of an injury or into success, physical success with the embouchure and with movement. It really has to come from the entire system. I think when we're practicing, we're forming new processes, and the next step is to consolidate those processes and strengthen the ones that are successful. And those two things, they probably happen in parallel to some degree, but the time frames are different. And so as and you've probably experienced this, you're practicing a passage and you get it perfectly, 3 times, and you move on. Okay, I got it. And you move on to another difficult passage, and then you come back to it and it's garbage again. Because
every day.
Because those two processes are happening in parallel. And so coming back to something again and again allows the consolidation to strengthen, but also giving yourself that time allows the consolidation to happen. At a molecular level, there are things that happen at the time frame of an ion passing through an ion channel, billionths or millionths of a second. And there are other things that are happening in cells and in synapses that require the movement of proteins across the cell and the modification of the synapse and the translation of DNA into proteins. And these things take hours or days. So we have to kind of appreciate both.
Are you talking about, is this like the lining of neural pathways? Is this kind of in that ballpark?
By lining, you mean the formation, or?
Yeah, so like as far as I understand, when you're trying to kind of cement a neural pathway, it's about the coating of that neural pathway. Is this kind of what you're talking about, or am I way off?
You're not way off at all. So the coatings in the brain, that those layers of the sheath along the wires, so to speak.
Yeah.
They're, for the most part, in the brain, they're somewhat fixed. I mean, you can get small changes in the amount of that wiring and the coatings and how they're configured. But the thing that changes more often is actually the style and conformation of the connections between cells. Those things are actually very varied and variable. So when we're thinking about it, like neuroplasticity, the most important processes are happening at the synapse, at the connections between cells. And so there's this saying that neurologists, neuroscientists, I'm going to apologize because it's almost it's almost not even worth saying, but those cells that fire together wire together. The cells that are active at the same time, those synapses, those connections are strengthened. But it is the process that you're talking about, the consolidation and formation of not necessarily new pathways, but new routes through existing pathways. The strengthening of specific circuits over others.
Yeah. And so that kind of feeds into my next question about habits, like good habits, bad habits, neural pathways. So would you say that like that? So we're kind of talking about practicing music, but if we get back to a movement disorder or even like activating a muscle or going back to more of the physical thing, is it the same thing? So I remember going through my injury, I would been doing these 5-10 minute slots per hour to really just give it everything for that short amount of time to try teach myself, then give myself a break, then come back and try recreate that. So maybe so we've spoken about the musical, maybe you could talk a bit about the physical, maybe it's the same.
So just to understand the question, you mean how can we best train the physical aspects of music production, or retraining of physical injury?
Yeah, or retraining of any kind of physical movement. Like, is it the same as the mental side?
I think it is. Yeah, I think it is the same. Because what the source of, when you're learning any task and learning any movement or learning a new thought process or anything, I think it really is all about repetition and the correction of error. So that the brain sort of detects error and then compensates for that error. It is a very, very complicated error detection machine, and then it modifies action to correct that error, and then remeasures the error. And if there's been an improvement, that it moves a little farther in that direction. That's one metaphor, one analogy to how it works. So at a physical level, I think you're using the same processes, and the cue is in that physical, whatever it is, an embouchure. The cue is probably the sound production, and you're using that sound production, or you're working through the passage to cue changes in the physical conformation of the embouchure.
To throw another dimension in, often for myself and when working with clients that I'm trying to help, throwing the dimension of a mirror in, it adds a whole nother thing. So I could, on a playing level, I'd be like, oh, did you know that your chin's wobbling when you get to the top of the stage? They're like, oh, it's not wobbling. And then they see it in the mirror, they're like, oh yeah, it does this thing. And then actually sometimes adding a mirror, people can go to that place and stop it from happening just with the visual cue or visual aspect. And a lot of what we're doing, what we will be doing at the Embouchure Project with a lot of the cross training, like off instrument stuff, is like awareness of the muscles in the face. And these are hard things that people find hard to do if they're looking, but if in front of a mirror, as soon as you add a mirror, it's a little bit easier. Do you want to maybe touch base on this aspect?
Yeah, well, I think it comes down to the fact that these movements are really not very natural. People don't make them at all.
Yeah.
And it all comes down to once the mouthpiece hits your face, then they seem more natural because they're practiced, but there's nothing inherently that you're never doing, you're never doing that in daily life. There's no role for those movements outside of music.
Yeah.
And maybe talking to a baby, you know, making funny sounds around a baby.
Yeah.
But I think what you're getting at is the recognition and the recognition of a cue. So, you know, something that somebody might not be able to feel, they then are cued into, and maybe they then can start to, oh, actually, now I can see and with the tremor, and I can now feel it because I have closely associated those things. And this movement that I wasn't detecting before, now I can internally detect. So I think that there's a lot of power in that technique because it aids in the formation of cues that can then become internalized.
Yeah.
But do you know what I mean by that?
Yeah. Have you dabbled much in stimulation, like facial like touching and stuff like that, on a skin level? Have you found any success with doing that, or not so much?
No, I haven't. But maybe you have in your experience.
Yeah, a couple of things. Like even so let's talk about the corners, because I find this was kind of a game changer for me, and why it still kind of blows my mind. So the buccinators are our corner muscles, and they're the only muscles that anchor into the face. And even just so that feeling of the corners hugging against your teeth, and you can kind of do it when you're playing, but even just the touch, it's like, oh yeah, like you can really, even just that touch, and then that kind of reminds the body, it's like, that's what it's meant to be doing. And it just gives you, like a drug, it gives you a little hit of, oh yeah, that's where it's at, and it lasts for about 5 minutes, and then you let it go. But yeah, I just find it really interesting of because it is such an unnatural thing to do all these things. Just any tips that I can get. I mean, I'm used to it now because I've been doing or showing people these movements for so long, and trying to explain it, like smelling something bad, or like Priscilla, Queen of the Desert. I don't know if you saw that movie, but they do this. All these and different. It's funny, different wording. Everybody will have different wording for a movement, or yeah. It's just a question. I'm just fascinated to see your thoughts on it.
Well, I think that there's there's two aspects of that I find interesting. One is how expressive you're able to make your face in these ways that most people just don't use it, and it speaks to the amazing degree of control that we have over the facial musculature. I mean, this is there's so much of the brain's motor control area. It's the primary motor cortex, it's called, but the strip that controls the action of all of the muscles of the voluntary, the actions of voluntary movement. Right. So you've probably seen the diagram of the homunculus, so to speak, that the human being that's sort of drawn over the surface of the cortex of the brain, and it's all distorted, and the face is really big, and the foot goes off, and yeah.
There was an artist that did a sculpture based on that, and the head is 20 times bigger. So the head is the biggest thing, and then the hands, and it's fantastic to see that. It makes so much sense. It's why your tongue feels like a huge, like the biggest part of the body. So
right.
That's it's, and when you go to the dentist and you're lying down and they put the mirror on, and you think your mouth is huge, but it's this tiny little filling, but it feels like the size of the Titanic. That's really fascinating to know.
Well, and it's all tied back to what I was saying before, right? Is the evolution of the brain's structure in terms of our own evolution as social beings, right? In this physical and ecological context, we're growing up and evolving around all of these other human beings, and the muscles of facial expression are the way that we're able to maintain order in these societies and prevent ourselves from being bludgeoned to death, right? So it's important that our brain is able to control our faces really closely, but the kinds of things that we do as brass players we're just never taught to do otherwise. So cueing yourself with a mirror, or cueing yourself with touch, those it sort of facilitates those somewhat unnatural movements that we're having to do, with the risorius and pinning the corners of the mouth in, and the buccinator, you said, keeping tension there, but
Yeah.
keeping the orbicularis fairly loose and supple,
Yeah.
while also maintaining tension at the corners. It's very complicated.
Yeah. One thing that I found personally, and I find a lot with clients that I'm working with, is we can get to a position where you form an embouchure off. So I'll talk about my personal injury 10 years ago. So I got to a point with Dr. Bronwyn Ackerman, who you've met, where we could form an embouchure off the horn, and I was able to free buzz. But as soon as I would bring the horn up, and there would be that physical touch, so things would fall apart for me. So, and I find this actually in a lot of people that we work with, is we're able to get so we're able to rest, rehabilitate, strengthen everything again, but it's just the physical touch, some way that the brain and the physical, like the mental and the physical, is so closely, annoyingly kind of linked that it's just this like fight or flight. It's just the brain just panics and everything lets go. And I don't know how to explain that. And I think we've kind of touched on it already, but this was another question that I had for you in kind of 100 words or less. Like, what's happening there?
In 100 words or less in my reply. Oh, good luck. Well, so there's two things that I think I could touch on. One is the effect of touch and sensory stimulus on dystonia, which maybe you've spoken to other people about the importance of sensory input in dystonia. And the other is about context, and the third is about output in terms of the air signal. So let me ask you, is it when you're trying to make a tone or a sound that everything falls apart?
Yes. Not anymore, luckily, but yeah, it was.
Right.
It was stressful, and I see other people going through the same thing. I find it quite happening quite a lot.
So I wonder, I would maybe address the last of my sort of three things first, because it's as you're trying to produce a sound on the instrument, your focus is so much on that sound production, and creating the tone that you want, because your entire life is focused on that thing.
Yeah.
That it's possible that just overrides the training that you put yourself through off the mouthpiece.
Yeah.
So you perhaps, and maybe this fits with your experience, you have to accept a very, very poor quality of sound and capability in to retrain the muscle.
Yeah.
Is that true?
Yeah, and it's great to hear you say that, because in brass pedagogy, we hear a lot of like, if the sound's right, then it's all good. Like, think about the sound. And I think there's definitely a place for that if you're a healthy player. And of course, in the orchestra, I'm not thinking so much about what I'm doing. I'm thinking about the sound and matching with the section and intonation, and because I'm at that level again. But when you're trying to repair something, you can't worry about what's coming. You have to think about the process of what you're doing and not the result.
Very much. Mm-hmm.
Yeah, and not chasing the sound. So yeah, it's great to hear you back that up. And I think there is a camp where both approaches can exist. Yeah.
Well, yeah, of course, because at the end of the day, you need to start making music again. But at the very beginning, when you're trying to overcome, some very severe, whatever it is, a mouth opening dystonia or a tremor or whatever it happens to be, the output that you're using as your signal, your error code, it can't be the tone, because it's going to be garbage. Well, I shouldn't use such a strong term, but it's not going to be good. It's not going to be good because you're starting from scratch. So you get the mouthpiece up to your face, and you tell yourself, set up, big breath, fix this, relax that, and you go to make a noise, and it's not the noise you want, and you fall into bad habits, because all of a sudden all of the stress and tension that is revolving around your ability to produce a good tone it's evidenced in that very second by a bad sound. And so of course you're going to try to correct in the wrong way. That would be it's interesting that fits with your experience.
Yeah, both personally and now working with other people. So,
but the other aspect of it, and I'll do this in 40 words, is that is that sensory input is so important that it's a characteristic of dystonia, right? It's part of it's one of the supportive diagnostic features. So somebody with dystonia of the neck that's pulling their neck extremely hard to one side may be able to place a finger lightly on the chin to resolve that. And that's not then pushing the head back. It's a sensory cue that somehow resets or alleviates the severity of that pulling. And it's been called in the original French, it was described by one of the pupils of the man who described the first genetic dystonia, whose name was Oppenheim. But anyways, in the French, it's called a geste antagoniste, a sensory trick or a sensory geste. And so there is a contribution from the mouthpiece in providing a sensory stimulus that is certainly changing the motor output as well. Okay, that wasn't 40 words, but it was not as many as I could have done.
Yeah, love it. We might talk a little bit about performing and nerves and stuff and performance anxiety. So obviously performing can be stressful. Would you say nerves and fear are the same thing?
I think that fear is probably more, in a general sense, useful than nerves. Because what nerves, anxiety, these sorts of things are somewhat unique to human beings, at least in the way that I think about them, because they're anticipatory. They require some amount of forward thinking. And I'm not sure, this is just me, this is just the way I think about it. So I'm not sure if this is supported at all, but I'm not sure that a dog really becomes anxious in the way that we become anxious. They can certainly express signs of discomfort and when people go away. But when we're thinking about, the concert that's coming up and what it's going to mean if I don't perform the way I want to, and what that's going to mean for my family, and am I going to be able to pay my bills? And these capacities just do not exist in anything but human beings. So, anxiety is, I think, related to forward thinking. Fear can be very useful if it's appreciated for what it is, and fear is more immediate.
Yeah.
But what does that mean? What does that mean in its relevance to playing music and retraining an embouchure dystonia?
I think definitely, like, there's a huge part is like coming back from an injury. So for professionals, it's really hard, the return to sitting in the orchestra. I mean, there's a lot of fears about that, a lot of anxieties about that, in terms of, is it going to go right? I mean, when I went back to my job, I still had to have a mirror on my stand, a little makeup mirror, just as a comfort thing. It almost became an addiction. I could always check in on the mirror, that little mirror, just to see, okay, cool, I've got it set up right. But yeah, and it might be out of your pay grade, but I just thought it'd be an interesting question to ask you and see what you came up with. Yeah.
Well, yeah, I think that's the way that I would separate it out. But I mean, the anxiety perhaps isn't useful, but in that moment. But I'm sure the fear of forgetting, the immediate tendency to check the mirror was probably very useful for a little while. In maintaining the external internal connection between those cues, and you would say that it's a crutch, but I think that it might have been for a period of time a way that you comforted yourself and allowed yourself to be confident in the internal cue.
Yeah.
How long did it take to transition away?
Not long. It took a couple of confident weeks in the orchestra. The first week that I went back went really well, and so the fact that went well, and then building up on that, then within a couple of weeks. I was kind of confident enough that I kind of am at the back at that level. So, but
I mean,
just in the process of rehabilitation, we use a lot of mirror work and trying to get people away. And I remember myself as well doing something in front of the mirror, then trying to replicate it away from the mirror, in front of the mirror, away from the mirror. But this, just interesting play on the brain.
Yeah, and I think it is that is likely a natural and necessary process of transitioning to full independence. I mean, even when we're training people around a broken leg or after a fall with a broken hip, I mean, you start them with a walker and transition them to a cane, and then eventually, not at all times are they going to be independent. Outside the home, they're still going to need assistance. So it is context dependent as well, right?
Yeah, sure.
Some things are just going to put more stress on your attention, and that's not going to allow you to focus on the things you can focus on. I don't know, maybe the more difficult concerts you had the mirror there, and the simple ones you didn't for a period of time.
No, just trying to hold on for dear life. So.
We all are, yeah.
So a large part of what you do every day in your research and practice centers on movement disorder. For the musicians listening, what should we? So, would you say there's anything that we can do to lower the risk of developing a movement disorder, or what are the big telltale signs besides from a tremor? What would you tell the audience?
I struggle with this question because I don't think that we really understand what predisposes certain people to developing dystonia. There's some research to show that there's a personality subtype that's very driven, and
or genetics I've read as well.
Oh, certainly, absolutely. And I'm not even really considering the effect of genetics and perhaps even a mild underlying generalized dystonia, or perhaps a stroke or a brain injury in the past. Those things can certainly contribute. And it may be that some people have a gene that would not otherwise cause dystonia, but because they're so very highly trained as musicians, they actually do develop a mild limb dystonia or something in the face. Let's just put that category away, because those circumstances are probably less common. Although, we have not studied musicians sufficiently to see, well, maybe many of them do have these predisposing genetics. So, it's just very incompletely understood. But I struggle with this question because I think it's, it's not data. Any answer that I give is not going to be data driven. And I think that what we need to do as a field is move away from the charlatan snake oil salesman, individual genius approach, and towards a data-driven approach. And we're only just starting to get there. So I don't want to lead people into thinking that there's something that they should or shouldn't do, and we just simply don't understand why somebody can practice intensely, a violinist for 12 hours a day, and another in music in their master's or undergraduate music degree develops a focal dystonia after only the first year and a half. We just don't understand.
Yeah, I'm glad you said that, because I think that's what we're going to try and do at the Embouchure Project is have a full panel of expertise in all these different areas. It's not fair to someone with, it comes back to the question, when you have an injury, who do you call? Because a great teacher doesn't have the medical expertise of pointing out something like focal dystonia, or but a great doctor won't be able to explain it to you in musical terms, some exercises or whatever. So I think, having trying to get more of a multidisciplinary approach to treatment, it is the way forward. And you're right. No one person can say this one gadget will solve all your problems, because like we've touched on just in this talk, there's so many different things at play that affect the whole system of a musician as the person and the musician and the technician of what they do. But
I think I'm really excited about the work of the Embouchure Project and trying to establish treatment protocols and trying to study these protocols and like you said, the multidisciplinary approach, but bringing musicians in as the really the community that is affected by this, and that setting the priorities of the research and clinical practice is so important, because as doctors can often focus on the wrong things and go down a garden path where these things aren't really meaningful to the community. So it's important from the very beginning. I think it's exciting that we're understanding where the priorities are and we're focusing in those areas, or at least trying to. And then reducing the stigma, right? Because that's a psychological factor that's just not necessary. It's so much extra anxiety.
Yeah. I mean, even in my time as a professional musician, I feel like I know that 20, 30 years ago, it was never talked about. People just, if something happened, they lost their chops and they were swept under the carpet and they disappeared and did something else, even until, very recently. But now if someone has an injury, it's more accepted that, they're having an injury, they're taking some time off, they're seeing somebody. It's madness. You only have to open the newspaper and read the sports section and you get a whole breakdown of an athlete that's injured, what their injury is, how they're being treated, how much care they're given. But you'd never read in a concert program something like that. Imagine that in 10 years time if that could happen. But anyway, we could talk for hours, and I really, really appreciate your time, Xenos. It was fantastic to talk to you and to hear from an expert everything that you had to say.
Well, I appreciate it, and I especially appreciate you allowing me to go on and on and on. That was very generous of you. So thank you. Yeah.
Of course. Thanks very much. See you later.
Thank you. See you soon.
Thanks for listening to this episode of the Embouchure Project podcast with me, Frankie Lacerda. The strength of this project is our network, so please go to theembouchureproject.org to sign up for our mailing list, follow us on Instagram, and join our group on Facebook. If you have any questions, please don't hesitate to email us at info@theembouchureproject.org. We look forward to hearing from you.